first.
Oh,
Hopefully this.
Were you the very last?
I never.
Yep.
Okay, I didn't know.
Where do you like?
Yeah, you sit over there.
Creatures of battle.
Okay. Keep staring.
Is it from the group?
Yes.
I
I just own one. Yeah, it's like a very sweet and oh my god, it's so awesome. Yeah, and she's kind of a man, right? You know Carol. She's too much like Mach 10 or something, right? Usually Mach 10. Yeah, hi, nice to meet you so much. And I'm sort of, yeah, I just got a visual, so like, you can, and then you can share it that way, that's what I usually do. Yeah. Yep.
No, we did password.
You can send it to me.
No.
Okay.
It's that easier. Oh, you did?
You know what?
Okay. Yeah. Yep.
Fantastic.
So.
Nice
there
to
it
meet
is.
you. I feel like I called 16.
I am, yes. Yeah, it makes little feet.
Good.
Thank you. How's the conference?
Good.
They haven't started yet.
4 days at the office. It feels like, right?
Yep. So it's like 6:45 West Coast time.
Oh, it's good, that's
Sure,
right.
yeah.
Right.
Teams or is it? Teams.
Put in a bill that.
Just easier. I like YouTube. Then you don't have to really participate. You don't have to think about it. Yeah.
I just need to double check.
Hey.
I'm just. And so. I'm there for that book. Most of it would be for sure. I'll complete the same.
Good. Think so. How about yours?
They are. He's going. Yeah.
It's a relative. Harmless. It's the thought that counts.
I just need people to have my back here. Yes, I can. I have two and one on the left. No. No. And the blue shrine is donated this weekend.
I'm working, okay. Okay.
Mm.
I thought you were by me inspired.
And it's called the Or would it be trade? Oh. I mean, I would be trade, but, and I would have been on the B tree. It was very,
Yeah, it's
and the kids loved it.
Oh, there's something. All right. Are we more or less ready? I know it's a couple minutes past 10. Okay. Morning, Henry.
Morning, how are you? Sorry, I'm
Good.
remote today.
No worries, no apologies. All right, well, let's call this morning's meeting of the Medicaid Advisory Committee to order. I know the first minute is supposed to be introductions and announcements. So for those who didn't walk in with us, I would love to introduce you to Teresa Gustafson. She's my alternate. She is a Director of Guardianship Services at OPG, 17-year veteran, meeting people in person whose names she's seen around for a long time. But she thought it would be fun to come in person. You've got a lot of DHHS current and veterans in the room. And yeah, thanks for having me. Nice to meet you all. And on screen, I should say too. Most of the members participate remotely, and it is a meeting that's open to the public. So there are lots of people online who are not voting members. Okay, Kristen, I saw your note on Friday about the October minutes. Should we skip that for this morning?
Yep,
Yeah.
that's not ready.
Okay, that's fine. No worries.
But it'll be ready for
Okay,
December.
okay. No
Thanks
worries.
for the heads up.
Yes, appreciate it. So we're already making up time. Do we have suggested agenda items for future meetings from any of the members? Are you seeing anything in the chat?
Mike.
Hi, everybody.
Oh, Mike,
Yeah, no, I'm not sure if it's an entire agenda item or if it's something that needs, but we've been following
morning.
a development with the Board of Dental Examiners where they're replacing some rules regarding sedation for young children. The reason I wanted to bring it up with you all is that we have deep concerns that adding another person and making the rules for sedating children, which, you know, this was supposed to focus on emergency cases, is going to cause an immense access issue because now they're talking about redoing the sedation rules and increasing personnel. I know Sarah Finney has voiced concerns about the impact on the Medicaid population, and I just want to put it on everybody's radar screen.
thanks, Mike. Anybody else? Right, we'll take that note.
Can someone?
Folks could mute, yeah, that would be.
All right, okay.
Friends online, if you would mute your line, that would be great. Thank you. All right, next up is Rob. He's going to share the current collection of LSR titles. Legislative service requests. Pre-bill.
So we're still very, very early on. We haven't seen a lot of language for anything. They should be published late December, early January. So right now we're just really working off of titles. So I don't have a lot more information for you other than the titles of things. We are beginning the governor's phase of the budget. I believe hearings began last week for those. But with that being said, we've had a few more added to the list since last time. I'll just briefly recap some of the more interesting ones from the first batch, and then we'll go on to the new batch. So we have relative to state participation in the Medicaid Direct Certification Program for free and reduced price school meals. This is a bill that's been, I guess, perennial. It's been appearing probably every year for the last 2 or 3 years. So we, it's primarily an education bill, but we do partake in it and assist the Department of Education with any information they need for it. We have relative to the use of electronic medical records. This was also a bill from last year from Dr. Nagel, our Representative Nagel.
So he brought it back.
He did bring it back. And I haven't seen the language yet, so I don't know if he's kept any of our original suggestions to it, but we'll see. We have establishing as its own state agency a Department of Children and Families. So that'd be a pretty big reorganization for the department should that go through. That's a bill that pops up every once in a while. Over the last 10 or so years. We have directing the dissolution of the Department of Health and Human Services Office of Health Equity, Department of Environmental Services functions for civil rights and environmental justice. It's a big one, but that would reorganize the department as well by getting rid of our Office of Health Equity. We have, now we're moving into the newer ones. We have permitting the Commissioner of Health and Human Services to authorize additional beds for pediatric intermediate care facilities under certain circumstances. And that's a bill from Senator Rosenwald. We have requiring that a public body's meeting minutes include start and end times of the meeting and printed name and signature of the minutes preparer. So I brought that up just because that would affect MAC, particularly Kristen. So that is from Marjorie Smith. We also have another one for her relative to public meetings. We have making preliminary drafts circulated to a quorum or majority of a public body available for inspection and specifying additional record provision requirements and options. So that's another Marge Smith bill. Quite honestly, I would have thought that if it had been circulated to a quorum, it would be public record. So I'm not really sure how this changes anything, but I haven't seen the language, so I don't know. And then the last one is a department requested bill. Can't really get into the language yet, but it's relative to Medicaid pharmaceutical services. That has just been put out there. So that's what I got so far.
Thank you.
Probably in January, we'll start getting more substance as we have language, and we can talk about it a little bit more.
All right, any questions for Rob? Hearing none. So let's turn it over to Dave and Kelly for the ongoing metamorphosis of MAC and BAC.
Yep. Thanks, Lisa Brett. So folks may remember we had originally presented back in June or July about some new CMS rules and changes to the MAC and the requirement to form a beneficiary advisory committee. And so those changes go into effect July of 2025. And so this is just a link to the final rule. And then to get into just a reminder of the summary of the proposed changes. So states are required to establish a separate beneficiary advisory committee. And then 25% of the MAC needs to be members of the beneficiary advisory committee. And to be a member of the BAC, you need to be a current or past Medicaid enrollee or a family member or a paid or unpaid caregiver of an enrollee. And then the MAC is there aren't really changes to the member requirements of the MAC other than just CMS made clear that MACs must also now include representation from participating Medicaid MCOs. The rules also established terms and term limits for MAC membership, which essentially will prohibit consecutive terms of MAC membership. And that would go into effect July of 2025.
Membership or?
Members. So a member wouldn't be able to have a consecutive term.
How does that impact organizational members? Same thing, like.
I think so. So the organization would be able to appoint a member, but I think we need to look a little closer as to whether or not it would be the same individual or they have to appoint a new representative for that membership organization.
But the org could stay, it would just have to be a different point of contact.
I think so, yeah.
Sorry, Kelly, I didn't mean to jump in. I was wondering if that was the same thing you were thinking, but.
No, I knew it was, officers, I just didn't know it was all membership. And so it's very helpful for me to have the clarity as we continue it through this conversation.
There's, I believe, flexibility on the length of terms. Is that
Yeah.
right?
Yeah, I don't think CMS didn't really dictate the length of a term, and left that up to states. So,
I wonder I think a number of us have moved to different organizations and have continued to participate in the new role. I guess I'd be curious as to if that's something CMS would allow, if the department decided that was helpful or not. Would be interested in that.
But we've got a pretty shallow pool here.
Right. That, I mean, which
It's
is
like
why many of us have
people
been in
really-
different organizations and still come here.
There's a question in the chat. Could an organization rep also count towards a BAC? Can you have a dual role?
yep, so the MAC needs to be 25% of the MAC members need to also be on the BAC, the Beneficiary Advisory Committee. So there will be some MAC members that have a dual role.
And sorry, the last just question, is it each MCO has to have representation or is it a representative of the MCOs collectively? Do you
I
know?
don't think we've made a decision on that yet.
Thanks.
No problem. And then another future requirement of the rules is that an annual report gets released summarizing the activities of the two committees. And then there needs to be a home and community-based interested parties advisory group, which we think we could incorporate into either the MAC membership or the beneficiary advisory group membership.
So for us really, as we're talking today, the point today is to reintroduce that there are some changes that we have to accommodate. We're gonna need to dive into that language. Dave's gonna tell us a little bit more, and then we're gonna come back to the notion that we've been socializing with people around participation and informing the membership.
Yep. Yeah, and I think the big thing for the initial compliance deadline of July 2025 is recruiting members that could populate the beneficiary advisory committee.
Sorry, but Holly had a question for the BAC. Does the family member have to be New Hampshire Medicaid or just any state Medicaid?
I don't know. We haven't made a decision on that. I don't think the rules dictate. I'd have to look into it though. But I think we'd be most interested in New Hampshire Medicaid because it really is to help inform the Medicaid, the Division of Medicaid Services on implementation and policy and things like that. And so this is just sort of a slide on the future process and our proposal of, so in July, the BAC would be established and then the meetings would be on alternate months. So the BAC would say meet in July, the MAC would meet in August and sort of continue in that manner.
Question,
That's-
comment?
I'm sorry. Oh,
Go ahead, Henry.
yeah, thank you. The reason that the sequence is I think part of the rule, David, is that the BAC's supposed to happen before the MAC meeting, and that's why it's kicked off that way.
Yep. Yeah. So the CMS rule was pretty clear that the BAC needs to inform the MAC. So that's why we would have the beneficiary advisory committee have the first meeting, and then that would inform sort of the agenda and the discussions at the Medicaid advisory committee meetings.
So in the way back, we used to have 2 or 3 beneficiary members of the old MCAC. And it was really hard to recruit. And I think that what the beneficiaries came to the table expecting was not necessarily what they got and vice versa. And I think a lot of the content was so wonky that for a beneficiary, it was basically noise. And that when they sort of tried to raise a concern, I don't know that they really felt like they felt heard. So I'm hoping, like, as we try to nurture a committee of beneficiaries, that we ensure that it's meaningful and that it is a real opportunity for them to sort of share their experience and inform direction. Because I wouldn't want to see sort of a repeat of the past where it was just so difficult to get beneficiaries or, family members to join this committee because it must have felt like a real drag. It added no value for them.
Yeah, I think that's something we definitely want to avoid and completely agree. That's a very good point.
I think there might be some good examples. The MCOs have to do or they used to have to do those beneficiary advisory groups. But there might be some, lessons there or opportunities that can be borrowed for the Medicaid Beneficiary Advisory Committee. Gift cards help. Motivators.
Henry, were you trying to say something?
I was just gonna say, I think some of the work that you talked about, Lisa Britt, that's sort of technical and not necessarily germane to their day-to-day receipt of services, that by separating the two, I think gives a better opportunity to do that. Plus, today we also have the remote option, which I think will be helpful to people, particularly who have mobility concerns.
That's a great point.
And this is Ellen. I can't tell if my hand is raised or not. I tried to raise it, but I just wanted to say those are both really good points. And I think this is a great idea. I think that some of the concerns that you spoke of are very valid, and it would behoove the committee to choose very wisely some what I would call interpreters, so to speak, that would be able to explain a lot of the policies and the information that they're going to hear about in the MCAs in terms of how it does apply to the personal experience of the consumers that are at that meeting. And so I think that it really hinges on having some folks there that are a part of it that can make it germane to the personal experiences of the people coming to the table. Because, I mean, even with a master's degree, it's hard to decipher some of the stuff that we talk about sometimes. So I think that's a really good point, but I think it's doable. It just requires a very mindful setup. That's all. Thanks.
Lisa DiMartino, you have your hand up?
Lisa?
Lisa? You
Yeah, she did, but
You
she
did,
must have
but-
it done. Any more questions?
Oh, she wrote it in the chat. Oh, she can't get her mic to work. Can you write it in the chat?
All right, well, we're hoping that Lisa will be able to get that into the chat. Oh, right, Joan has a question now too.
Well, I wrote it in the chat, but Henry beat me because that's what I was thinking too about, comparing to your other format or your previous format. We didn't really have the virtual option, which may be a good thing for some of your beneficiaries with disabilities. And of course, then we know computer access is a challenge. So I think just making sure we understand the kind of support that our beneficiaries need to engage in the process. Thanks.
So I think that going forward, Dave, when are we thinking about moving this conversation? In January or?
Yeah.
So in January, we'll be looking for people to participate and inform our formalization of the BAC and the rules and making sure some of the questions that you all have are answered. I know Henry and Lisa Britt and Dave and I really feel it's an opportunity to ensure that the voices that want to be heard, have an opportunity to be heard, but just creating an opportunity, like, I'll use an example, putting a notice of a spa in the newspaper, right? That's a notice of opportunity. That's not gonna be enough here, we all know that, so please, just let's be really creative about how we can make sure that people have the opportunity to really influence a program. The department's open to having that kind of feedback. Dr. Lotz, I've already put your name out there to help with the MAC and BAC, so I passed that along, last we met. And, but we're gonna have this conversation in January, and we're really hoping that people are going to want to participate in the continued conversation.
Awesome. Thank you both.
Sorry.
Oh.
Karen? Your mic's off.
Sorry. So I think that it would be really helpful to think about whether you could offer a stipend to folks who are beneficiaries to enable them to participate, or at least cover transportation expenses they might incur if they want to participate in person. And also think about what really pithy, short, attractive information you could put together in kind of like the advertisement or something that our organization and others could help circulate to folks to try to generate some interest.
Yeah, I'll say, there is no shortage of people who I think would want to influence. We have to be able to outreach them and engage them in a way that they know that invitation is open. And as Lisa Britt said, make it meaningful. I know when I went back from the department to Center for Life Management, early on, we were on a peer support initiative, and all centers were having a hard time in getting staff and peers. And the day they said, where are we gonna get peers? We're having a really hard time. And I said, they're in the waiting room every day by the thousands. They are here. And we changed our approach to engagement, and we have really great success getting peers in. So.
Good job. All right, are we ready to move on to enrollment and eligibility updates?
So this is the October Medicaid enrollment and eligibility report. So you can see our ex parte for December remained high. It was 84%. For the past 4 months, it's been above 83% and in the high 70s since essentially November of last year. We are expecting some changes coming soon that will impact the ex parte rate. Last week, CMS issued an informational bulletin that makes permanent in part some of the flexibilities that we've been relying on. And these are what we've called the E14 authorities that allow states to process eligibility applications in a certain way to gain efficiencies and just help with the enrollment process. For states to continue using some of these, and the ones that are specific to this are we've used a zero income strategy and individuals with income below 100% of the FPL. That allows states to essentially ex parte renew an individual if they had zero income when they applied or were at or below 100% of the FPL, as long as the state has queried other data sources. And so CMS is allowing states the option to continue using those in the future, subject to some conditions and getting CMS approval of an updated verification plan. And so that just came out last week, and I think it is exciting news, but it will, while it's good news, it will impact the ex parte rate in the future. I think it will go down a little bit. And so we're looking through that informational bulletin and what process and system changes we'll need to make. But I think, it's a bit of good news there.
Question.
Yep.
So when you say that it would go down in the future because we're querying maybe more sources of verification.
Yep, and part of it is currently how we're allowed to use prior self-attestations at application. And so CMS doesn't, in the future, CMS doesn't want states using really old self-attestations to renew eligibility. And so if we're relying on a self-attestation currently, and that isn't allowed in the future, that person wouldn't get ex parte renewed, and they'd have to either self-attest to the income at renewal, or if we were able to identify electronic sources of income through their various different electronic data sources out there.
So then now there's two things. One is that people who were using self-attestation wouldn't concurrently applications keep using that, which makes sense.
Yep.
And then there's also the issue of where you have additional sources to query, you may verify that they don't still qualify.
Yep.
By the way, I see people who don't still qualify get ex parte, and we have to come back and say, yeah, no, this is my other source of income, or I'm married now.
Yep. That changes.
Yes, yeah, thank you.
Yep. So this is just an updated slide on, it's a view of where we were before the pandemic started, the increase for continuous eligibility during the PHE, and then on the right-hand side, where we are over here. So we're at about 181,000 in total population. That's 57,800 in Granite Advantage and 124,000 in standard Medicaid. I'll just jump to this slide because it gives a little bit more detail than the one that we were just looking at. And so this looks at the first of the month starting from November 1st, 2023 and tracks through November 1st of 2024. And you can see the changes in eligibility enrollment based on the different categories. So as we've seen and talked about in the past, we've seen increases in the CHIP and non-CHIP kids. And part of that is due to the continuous enrollment, the 12 months continuous enrollment that went into effect January 1, 2024. So right here. But we can continue to see those climb. So they're about 64,000 this time last year, and there's 66,500.
Can I ask a question?
Yep.
When you're watching that number and you're thinking about 12 months continuous enrollment, because we started in one spot, do you anticipate that number won't continue to increase? Or do you even think about it? Or do you anticipate that the number would continue to creep because there's always people moving into that 12 month?
I think at some point it'll begin to taper off a little bit. And the way the 12-month continuous coverage worked was a little wonky in that it wasn't, went into effect January 1, but say you had your redetermination in October, you still got the benefit of 12 months continuous coverage
From October,
as long as you were enrolled still on January 1.
Yeah.
So that person gets 10 months. And so it's kind of, and then when they renew, they'll get 12 months. Yeah.
Thank you.
Yep.
The other factor that's out there is, the school enrollments. We're seeing New Hampshire seeing some decline in children, the birth rate issues, but also income, right? New Hampshire has I think the fifth highest, meaning the most chance of becoming eligible in the country. And so some of what we had seen in terms of disenrollments in the children was over income. And so I guess depending on how the economy does, Kelly, that would also have an impact on what that looks like.
Yeah, understood. Thank you.
So this is the dashboard for adults for October redeterminations. So there were just over 8,000 redeterminations, 7,253 completed a redetermination, 783 financially closed, but the biggest driver of renewals was the passive. So of the 7,200, roughly 6,800 passively renewed. And similar story with children, there were just over 5,200 redeterminations, 4,500 passively renewed, 4,700 completed redeterminations, 326 closed.
That close doesn't, they might have moved into an adult category, correct? Just because they closed out as kids doesn't mean they've left the program, right?
It's possible that they did reopen in an adult category. The largest group, though, of the closures is failed to read, so there are 232 failed to reads.
Okay. Thanks.
And then 56 from over income.
Thanks.
Yeah.
Also doing the extensive outreach on the closures, right? Through Vern's team.
Yeah.
And the
we have a couple of
MCOs.
slides on that. Yep. And so in the waiver population for financial redeterminations, there was 1,175 in October. 1,048 of those individuals completed a redetermination. There were only 5 financial closures, 2 for income, 1 for failed to read. And this is a breakdown of that larger waiver population to just CFI. So there were 328 CFI redeterminations for October, 300 completed redeterminations, 2 closed. And there are some pending, and that goes back to one of the flexibilities we enacted during the PHE was to give individuals extra time after their redetermination date to complete it. So they show up in the report as pending. Similar numbers for nursing facilities. There were 314 redeterminations, financial redeterminations for October, 1 closure, 238 successfully completed redeterminations. And this is the CMS reporting we did for October. You can see the retained for Medicaid is high and remains high. It was at 91.6% for October. And if you look back at prior months, this goes back to November 2023. So in this orangish line here, it's been over 85% since a year ago. And this is both, when you think back to the unwind, we had the protected and unprotected population. This is the total. And these are the MEA reports from August and September that we went over last time. I don't have the October one quite yet, but there were, we highlighted the important lines. So there were 639 MEAs due for August, 667 for September. Of the MEAs that were due, 223 in August were completed, 252 in September were completed, with a large portion in each month of the MEA, the individual met level of care. There were only 21 in August that did not meet the level of care and 13 in September. But importantly, there were no MEA that resulted from a failure to provide documentation. So, Vern, you don't mind just giving an update on the communication campaigns that we're doing?
Lisa? Push their hand up. Dawn, I'm sorry, Dawn?
Yes, sorry, I just, going back to the MEA slide for just a second, David, I was wondering, how, have we tracked that, how long have we been tracking that data? Meaning, I'm just curious if the not meeting the level of care, the 21 that didn't meet level of care, if that 3% or whatever it is consistent with historically over years, or if that, you know, how that has changed over time. I wouldn't expect that to change much.
Yeah, we've had this report that we've been tracking. I I think since around June. So I could go back and look at prior months, but I think for the months I've seen, and it is a short period of time, it's been around in that 3% range.
Okay, so we don't have any like historical data going back prior to June.
I don't,
To talk
not
to
that
the
I'm
program
aware of. We
area.
can, yeah.
No, I don't believe we didn't track that prior to working with David and the Medicaid team on tracking this. So we don't have any of that historical data.
Okay, thank you.
So it might be a good idea if we can consider, but we can even talk about it in our planning meetings in response to Dawn's question, is to sort of trend it over time too. Month over month, even if it's over a 12-month period, can answer her question.
Yep. Or do you mind giving an update on the fall campaigns?
Sure. So last month, there were 566 individuals that had closed in the month of August for either reasons of failure to complete their redetermination or their required verifications. The MCOs made outreach to all 566. Everybody received at least 2 calls. If they weren't reached the first time, they had a second call done. If we look at the messages left, voicemails full or incorrect contact information, that information actually stayed pretty consistent with the previous month. We did find that readies that were complete and opened were about 5%. About 8% were aware that they needed to do their redetermination. 3% had new insurance. And about 1% had moved out of state. So we ended up with 387 individuals for which we left messages, or the MCOs left messages, sorry. This next slide is just a breakout of those that we reached. So there were 110 individuals who were reached. If we look at just that amount, 27% had already done their redetermination, 40% were aware and actively engaged in doing their redetermination. We are asking the question whenever the calls are being made for children, whether or not they realize that children have a different income level. No one indicated that they did not know about different income level for the children. And the other category consists of individuals who indicated that they or their children no longer needed Medicaid, but did not indicate to us why they didn't need it any longer. This next slide is the Medicaid medical unit, which is making outbound calls. And what we are doing with those calls is we are reaching out to the individuals which received a message, but we didn't get a response from in the previous month from the MCO. So in the previous month, the MCOs had 344 individuals, which they had not been able to actually have a live conversation with. Medicaid team was able to make an outreach to 150. The children within the message lists were those who had used services within the last 3 months. And that is how we look at acuity, that plus medical conditions. When we look at that, of those, we still was seeing a second round messages left of about 55%, but we did see readings completed 24%. And then looking at new insurance at 9%, 6% were engaged. And so this was 2 months after they had closed. 6% were aware and were engaged. Is this the last slide?
Yep.
Yes. Okay, thanks. So when we break this down and look at just the 150 that we received or reached, we're looking at 57% who completed their readings, 3% who had done their redetermination were ineligible. 14% are aware and working on, 21% with new insurance. And one of the things that we were able to do for the first time, because this is a new campaign that we started, is we looked at the redetermination complete at the time that the MCOs made the call, and then when the Medicaid medical unit. So redeterminations we saw go from 6% up to 12%. Those that were aware and working on them had an increase from 8 to 9%. And those with new insurance increased from 5 to 7.2%. So in our second round of attempted outreach, we did see numbers of individuals who either had new insurance or were aware or had already been completed their redetermination and come back into the fold with Medicaid.
Question.
Kelly.
So this is great. I'm a real numbers dork, so I like it, but you move way too fast for me, which we have to do in this meeting. But where my mind goes while I'm listening to you are, all right, so where are the gaps? Where are the risks? Where are the people that we want to continue to improve access or outreach to? And I don't mean from what you all are doing, like this is great. I'm thinking, what can we do, right, in the community? And what's the population of people here that are still falling through the cracks? And if we can learn anything about this information, and you can't, I don't want you to answer it now, I wanna maybe think about coming back to it another meeting, but if you were gonna say, all right, look at the department's doing everything we can here, but here's where the community can be helpful. These are where the gap areas are. That would be real valuable to us. Thinking about that going forward.
I mean, I'll just give you something real quick off the top of my head that I can think of. Having worked in primary care, when someone comes in, if they were to look and notice that their insurance is gone, that would be a flag. Oh, have you done your redetermination with Medicare or Medicaid? Because we indicate you don't have that any longer. Because we can make all the phone calls and send the letters, and we've had the different color letters go out to try to get people to open them. So just if you happen to notice it, mention it to them. It can't ever hurt to mention.
So I'm just gonna put out there for like the universe that's listening to this, what we do at Center for Life Management is every single day we run our 270 report, which is here's our people, and then the 271 report comes back. It's a nationally formatted transaction that says, and here's the status of those people. And every single day we populate and put a flag in our system so that if anybody looks at that screen, it says, hey, this person lost coverage. And we do about 5 different versions of this, some of which are manually, and we chase the people who are gonna see them every single day on the daily. But I'm putting it out there for people just to hear, like, if ever there's a conversation to be had for our membership on what are ways that we can operationalize or get access to this information, please bring it up as an agenda item, and we'd be happy to have that conversation and help you do that.
I know you guys got authority from CMS to expand the window of when someone presents for care, but they lost coverage, then you can retro it. Is that something that will continue to be in effect? Is that one of the ones that has been offered as permanent?
Yeah, so we have currently, we did a 120-day reconsideration period.
Yep.
The limit we have on retro though is 90 days.
Okay.
But we're.
So 90 retro, 120 reconsideration.
Thank you for those data points, because Kelly, like you said, I think all of us on this call are able to pick up the pieces, but I mean, you guys couldn't be doing more, I don't think, from the department to keep people and get them back, so.
We're trying, but I love the comment about you run those reports, and because The best thing about that is you can have a face-to-face. If the patient's there or the patient calls you, you're right there. You're 100% in front of us because they have to pick up the phone or open the door. So, thank you.
Thank you.
Okay. Does that conclude our enrollment and eligibility updates? Excellent. Great. So let's turn it over to our special guest, Peter Ames from the Foundation for Healthy Communities, about navigators.
Hey, good morning, everybody. I'm Peter Ames. I'm the Executive Director of the Foundation for Healthy Communities. I'm joined by my colleague, Stephanie Mervido, our Senior Director of our New Hampshire Navigator.
Hello, everyone.
Thank you very much for having us in today. We want to spend a little time talking about the Navigator services. And Kelly, you set us up so nicely because really this is about engaging the community with a resource that CMS provided to assist consumers and partners with finding folks that may be falling through the cracks and giving them direct navigation services. We'll talk a little bit more about that. But first, just want to do a little bit of level setting. Today, number one, we just want to give you an overview of the program so folks know what it is and how it can be used. Number two, talk about how we can be a partner to the community stakeholders as well as the department, and thoroughly ask for your help and referrals for consumers to access our services. The Foundation for Healthy Communities, we are a statewide quality improvement organization. We are an affiliate of the New Hampshire Hospital Association, but we serve a much broader constituency of both clinical and non-clinical partners on a broad range of health improvement activities, ranging from vaccination, substance use, emergency preparedness. But certainly a common frame in all of that is that quality care doesn't matter if the consumer can't access it. So that's why access to care is one of our foundational services, and we are growing in that space. Over the last 3 years, CMS had 2 Navigator Awards servicing New Hampshire. They put out a new award this past summer and consolidated that into one, and so now the foundation is the sole CMS designated Navigator organization in the state. And so we're going to do a overview of what that looks like and how to access it. So I'll give you the verbal for advancing the slide. You can go further a bit ahead. And one more. These slides will be available. They are kind of put together in a package so you can distribute that and share them, but I'm not going to spend all of them because I want to get to some more Medicaid relevant cases. But at our core, the New Hampshire Navigator program offers unbiased navigation services to any consumer in the state with a focus on the marketplace and Medicaid products. These are offered free of charge to any consumer, funded by CMS, and it is, we have no stake in any of the products that we navigate to. It's really a conversation about what's best for the consumer, both financially as well as their life. Next, please. So the navigation services, we offer several tiers of services, from online enrollment and telephone enrollment to chat enrollment, as well as video conferencing and in-person. The in-person service is the one I want to talk most about today. While we have that array of services, a lot of folks may not need in-person navigation, but CMS put a heavy focus on supporting those with the greatest need or who have historically been underserved. And this is where we certainly have experience that in-person navigation services are vital for those individuals that may often have more significant barriers. But that range of services is available for folks to access. New Hampshire Medicaid certainly is a very large piece of the work that we do. Right now, we are in open enrollment season, November 1st and January 15th. So the marketplace is the major focus, but we support Medicaid enrollment during the entire year. And so right now, we're certainly encouraging folks that may have lost products to go through open enrollment if they missed an earlier opportunity to come on to the marketplace. I'm going to come back to this in just a moment, but I can say over the last 3 years, we've had 1 navigator. We now will have 5. She has mostly worked on Medicaid enrollment. She's a Medicaid specialist by background, and we found that was the greater need. A lot of folks that have been on the marketplace for a number of years have not needed additional navigation services, but they've been able to self and re-enroll during every enrollment season. So that was a good trend to see. But we certainly got more requests, particularly through health systems, on Medicaid enrollment. I'm going to say a little bit more about that. Just a moment. Next, please. The marketplace right now, the expanded tax premium tax credits are still in place for this open enrollment period, so plans are very affordable. We have an additional carrier in the marketplace this year, so many options for consumers in New Hampshire, which is certainly good news. The challenge that comes with that is with that many options, it can be confusing for consumers. So that's where the navigators can walk through each of those plan options and products to see what aligns best for that consumer. So it's not just the price point, it's the life circumstance, it's what they expect to access, it's the network that is convenient for them. And so that is a key message of our work of why reaching out to navigation is important. Even if you think you know which plan you want to go with, it's worth the conversation. And I can currently say over the last number of years, a common story we've heard is folks didn't realize that they were eligible for a subsidy or Medicaid. They did not reach out. And when we were finally able to engage them, that education was illuminating to folks. So that's always tough to hear, but kind of speaks to how these services can be valuable. Next, please. And you can skip this one and the next. Right, CMS did identify a number of priority populations. As I mentioned, they wanted to focus on historically underserved communities, and so we identified these for New Hampshire in particular, low-income, rural and unhoused individuals, pregnant people, new mothers, and children. Certainly that is key for the CHIP products. Minority populations in New Hampshire, expand the range of clinical care systems, behavioral health, folks living with a substance use or mental health condition, and then LGBTQ plus communities. Next, please. Additionally, some areas that we will be directing resources to are clinical systems. Kind of to your point about having someone in person right there, it's such an opportunity, especially when they may be coming in with a bill or about to experience a bill. That is the time. So hospital systems and primary care systems are a key part of that. In-person Spanish-speaking support for individuals and partner organizations where that might be a forum. And prescription drug access. While there's nothing additional besides what you would expect with Medicaid products in the marketplace, we do help navigate folks to other services. And this is a key point to know, not just about prescription drug, although that's a very big one that we were asked about. But if navigators are asked for something that they cannot service, Medicare is a big one, right? We navigate them to a resource that can help them. So that is true for other social services as well, is that they don't do any enrollment with something that an individual may be eligible for, but they do find the appropriate partner to refer them to. And prescriptions is a very big one, as you might guess. Next, please. Spoke to that before. Next. And this is really just about how to refer to us. We'll attach the website when this goes out as well. But a couple things to speak of, more in particular to Medicaid. So Grant Advantage is certainly the most common area that we would work in, particularly right now with open enrollment. But I do want you to know that navigators can assist with any of the Medicaid products. We did see a fair amount of requests for long-term care Medicaid last year. On the way out, we were just talking about the barriers to discharge report produced by the foundation. Pending Medicaid is often a challenge with that. When our navigators got in there, and they got pretty far in the weeds and doing pretty much casework, right? It was sometimes just real basic logistical things, getting bank statements that they can assist on the ground with getting those completed. They also do training for clinical staff and systems. So if the navigator can't be there, we have like toolkits for some of the other Medicaid products. So we can go in there, do a kind of a train the staff in the system to help out with those other products. But they are available for other Medicaid products, not just what you would expect with Grant Advantage. One thing I do want to mention, kind of as we were speaking to the outreach that you guys have done, the MCOs have done, that is something that CMS is going to bring in some additional resources going forward as well. When the unwind was kind of at its peak, the navigators around the country got lists of folks that were coming off Medicaid so they could do outreach. Had very much the same experience that you might expect as far as a lot of wrong numbers, no answers, full inboxes. And so what CMS is going to do going forward, not just in the context of unwind, but as a service, as part of the navigation piece going forward, is that they will have a enrollment assistance program, which is a nationwide vendor to do some of that preliminary outreach after the MCOs. So it's kind of another layer. And it's getting really thin at that point because so much contact has been going out there. But We will continue that outreach, and when they do identify someone, they will hand it off to the navigator to assist them with what they may be eligible for. So that's good, an additional resource that may be helpful to all. Pause there. I think what I wanted to do now is just going to open for questions, but before I do, I did want to extend my gratitude to Henry, David, the whole department team for the partnership here as we've been expanding in the space. Certainly glad to have you collaborating with us, and we're going to learn from all the partners about how we can be helpful to folks out in the field. So I will say Bethany is just in her third week here with us, so I told her I would take the prime here, but she is our resident expert and leader for the project. So happy to answer questions.
Thank you guys for being here. A question and a shameless plug for your work. So I have worked with part of Bethany's team, Adrienne, for a number of years, and the work that she can do is unbelievable. So to have many of you guys available is really exciting. And I know we will be taking full advantage of all that you guys do. And so I would say it is an incredible benefit to our patients, to the Medicaid beneficiaries. So thank you for that. My question though is, as we talk about these conversations, you know, Kelly's organization is doing an incredible amount of work. As we all try to pick up the pieces that we can, do you guys have like a flyer or informational that we could put into place as part of your toolkit so that we could send it out with financial assistance, assuming that's appropriate and allowed, have to work with the rules, but you know, other things like that, or that we could help sort of connect patients with you and have almost a warm handoff, right? Like a step in between. Is there something like that that is part of the toolkit or that could be part of the toolkit?
Yes, indeed. And when we send out this, or materials send out follow-up, we'll make sure that is included for you all to distribute far and wide.
Thank you. Thanks for the work you're doing.
Other questions for Peter or Bethany?
I have questions, but I want to make sure anybody else that's online. Yep.
Yep.
Henry?
Thank you, Peter, for coming on. I hope that on future occasions we can have a special guest appearance to share as part of when we're doing some of our update on the experience here, what's going on with the group here. I think, and maybe quarterly basis to come back. I don't know if that's something you'd be willing to do.
Absolutely. Thank you.
We appreciate the work you do as well at the department level and look forward to working with you further, and appreciate that you're participating in our internal meetings now and then too. Thanks.
I have a little series of quick questions. Are you doing Medicare navigation?
Medicare, we are not.
Okay. So I need to, and when you say you have training for clinical staff, is that something we can leverage?
It is, yes.
Okay.
So you can just invite us in. We'd be happy to do an in-service for your team.
Are we making the best and most efficient use of the resource? And that you have time to measure that. I'm just wondering, like over time, are we reaching in when we should? Are we not reaching in enough? We have had the experience at CLM for up until now that we had a navigator available to us in a window of time, and the person who was the host was constantly coming back and saying to us, use your resource. You know, they all use me, but they need to come back to their community resources. So it makes me wonder, and I'm, you know, interested in your input. We don't want to overuse it. And so I have, you know, a team of a lot of case managers who have a job to do, and I need them to do their job without making referrals. But there are times where we just need someone else to look at it and say, here's the right options for this individual. So I'm interested in how we partner with you on that. You know, in the history in years past, and so I don't know if others had the experience, but 5's great, but only 5 all at once, right? And so how do we make sure that you're available to the people who need them without inundating you, but leaning into you when you want us to lean into you.
I can take this for you. So the number, there's two different numbers that you see on the screen. The 1877 number actually goes directly to a call center where there are navigators available to help people who are ready to enroll immediately. Sometimes people need a little bit more face-to-face. They need to meet with somebody in person. They need to bring all their tax documents or their medications, and they just need that extra personal touch. So our navigators cover different geographic areas and specialties within New Hampshire. So Center for Life Management is out of Derry, right? I live in Derry, but we have a navigator that's covering Southern New Hampshire. The whole purpose of our services is that essentially you could request to book with us and we could come to you. We could come to Center for Life Management when you have a client, or we could meet a patient at the Derry Public Library and sit down and hash it out with them. So if somebody is requesting more of that personal touch, I would recommend that they call the number or send an email to the email address. We are working on setting up a direct booking link so people are able to book directly within our calendars. And that can be helpful too in a clinical setting where you're there with the patient, and while you're there with them, you can put the appointment in with them in real time. So.
Do you have any fixed co-location? Like Mondays at the library in Derry?
Not necessarily. We work out of our Concord office 3 days a week and work remotely from home, but usually, anytime it's requested for us to be out in the field, we're mobile. And like I said, there's 5 of us in total. We're having somebody who's going to be covering rural New Hampshire, Coos County, North Country, which is a huge area to be able to cover for one person. And other than that, we've kind of spliced up the counties based on where we live, but all of us are willing to travel anywhere within the scope of New Hampshire to assist someone. Insurance is complicated, and sometimes you do need that personal touch of meeting in person and hashing it out, going through the application step by step, and making sure every single question is answered. So, and people's lives are complex. And
my last question is, do you have access to any resources that we just generally in the provider community may not have access to that makes it more efficient for us to lean into you? Like verifying income electronically, so.
Really not.
Okay.
Yeah.
And not that I can think of.
All right. Thank you very much.
You're welcome.
Other questions for Peter and Bethany? All right, hearing none, thank you so much.
I have to apologize. I have to excuse myself for a pop-up sick kid this morning. Monday you have all the ambition, like I'm on top of my stuff. I'm gonna be out. So my regrets as I manage that, but Bethany will be here and can stay up for questions that the folks may have. So thank you for everyone for your time.
Thank you.
Thank you. Will you need help in navigating that?
That's what Bethany for, right? You have me.
I can try, but I've only been through it one time.
Thank you. That's a good. I'm glad you asked before I left the room. We're walking around. I can't get out.
I'm trying to be observant. All right, so let's move on. Is Jordan on the line? And get an update on the Medicaid to schools RFP.
Yes. I didn't realize Medicaid to schools was first. Okay. So we have, and I think I updated the group on this last month, but we have been going through a process of, we had an RFI posted. We did some public sessions through the end of September on the RFI, collected feedback from that, and we've been making some revisions to our RFP draft based on all of that feedback. Right now, we're sort of in the final stages with the RFP. It's going through some legal review on the contract side, kind of fleshing out our attachments, appendices that will need to be submitted with RFP responses, and some of the IT requirements and needs for the RFP. But that all being said, I think our goal, hopefully, ideally, is to have it posted before the end of November for review. We can send that out when it is posted. Any questions? I can also note we, through our Medicaid to Schools grant, we have a project director, project manager role built in there for the Medicaid to Schools project. So that's specific to this CPE transition and managing the grant because it's an ongoing, cooperative with CMS. So that position is now posted internally to DHHS, and then next week we'll go external. So just as a heads up, if there's anybody interested.
Great. Questions for Jordan? Great. And seeing then.
Sorry, there was a question in the chat.
Okay.
Like Lisa Adams wrote back at 10:47. Where can we access those reports? I wasn't quite sure what it.
I think that was during Peter and your.
Because I couldn't see the chat while I was presenting. No.
Can you chat back to her?
Yeah.
What report she's
Yeah, I was
talking
gonna say,
about? Report
yeah. Sorry.
Okay.
Hi, it's
Thank
Lisa.
you,
Can you hear
Jordan.
me?
Yeah.
It was those reports earlier on. Basically, somebody said that they checked him every day for eligibility. And I was wondering how we could access those.
Oh, that's
Thank you,
Kelly and CLM doing the 270 for enrolled providers. Why am I answering this? You can answer this.
Yeah, so for enrolled providers, they can send essentially a request to the department through a form 270 for their patients to get an update on what the current Medicaid eligibility status is. And then the department sends back a data feed, which is called the form 271, with what that individual's current Medicaid status is, whether open, closed, spend down. Lisa,
And could agencies do that based on their? Would it have to be an individual, or could it be based on their census for the home care agency?
I think it needs to be based on the individual.
What's the question?
Okay, that's a project. Okay. Okay, thank you.
Hundreds, everybody, hundreds, go on it. Everybody we're currently serving that had Medicaid.
You essentially send them as a list of each individual that had Medicaid that CLM serving, and then the department, the electronic data reviews it and sends back the Medicaid status.
And so it's part of the national standardization of ANSI electronic transactions. It's in the same format as a claim form. These are the elements that you need for a claim form. Well, these are the elements that all payers need to use to, verify insurance. So it's a pre-templated report that you submit. All providers can do it every day. And you send in the whole batch, and the whole batch comes back, and it tells you all the information about that individual and relative to their eligibility at that point in time. So that moment. And for us, it really moved us forward on supporting people on a daily basis. We never did that before. You sort of moved through eligibility a month at a time, so the people had coverage. But once we got into the unwinding, it became very important to us, obviously, and so important that it's a standardized process that we do every day.
Did that answer
Okay,
your
great, thank
question?
you. Yes, it does, thank you.
Okay. Oh, Doris has her hand up as well.
Yeah, I wanted to ask Kelly as well. How common do you think that is among providers, and how long does it take you to run hundreds, this report?
So we don't really have to run it. It's automated transaction that happens every night. The file goes in, as long as you hit enter and the file comes back and it populates, it's an automated process. Like we do nothing more than take a second to automate the process. I think it's standard across most providers, that hospitals, it should be standardized. Like it's a very simple, national, standardized process. If you can file a claim, you can file a 270.
Any other questions? All right. Let's move on to Carolyn then, for an update on the 1115 for substance use disorder and SMI.
So I think this is my post-award forum time. So this is our annual post-award forum that we share every year at around this time. So we're up for this year's updates. So next. So this is just where we're giving you an overview of the SUD, SMI, substance use disorder, serious mental illness, dentures, and the new community reentry parts of our demonstration. This is the SUD overview. Back in 2018, we requested a substance use disorder treatment and recovery access demonstration waiver to allow New Hampshire to provide Medicaid payments for individuals under age 65 receiving substance use disorder services in an institution for mental disease. The request increases access to SUD treatment services for adults and adolescents in New Hampshire and was approved, like I said, on July 10th, 2018. The serious mental illness overview is we submitted an amendment request and it was approved on June 2nd of 2022 to coincide with the SUD treatment and recovery access portion of the demonstration. This amendment expanded the existing 1115 demonstration to include a waiver of the IMD exclusion rule for Medicaid beneficiaries aged 21 to 64 with serious mental illness who need residential or inpatient hospital level treatment. It was intended as part of New Hampshire's approach to addressing the increase in emergency department boarding and to support the comprehensive integrated continuum of mental health treatments and care available in the state. Initially, New Hampshire Hospital and Hampstead Hospital were the only providers under this SMI component of the demonstration. And on June 16th, 2024, CMS granted an extension of the demonstration for an additional 5 years, which will end on June 30th of 2029. The denture benefit is also part of our 1115 demonstration. That was implemented on April 1st of 2023. Dr. Finney did her demonstration, I believe last month or a few months ago. So I'll just give you a high level. The addition of removable partial or full dentures as a covered dental service for Medicaid enrolled aged 21 and older who are residing in nursing facilities provides the opportunity to examine the effect of replacing missing teeth on beneficiary health outcomes and quality of life. Eligible beneficiaries may receive dentures once every 5 years or more frequently when deemed medically necessary. Repairs for existing dentures are covered when medically necessary. The denture benefit is provided through a single managed care organization, Northeast Delta Dental, who works in collaboration with DentaQuest. This is the new community reentry demonstration, and we have a few slides for that because it's a new part of our demonstration. In addition to the SUD, SMI, SED, and dentures extension, community reentry was added as a Medicaid benefit for incarcerated individuals to receive limited pre-release services 45 days prior to being released from custody. The program includes Medicaid outreach and enrollment, enhanced care coordination surrounding the transition period, Medicaid medication-assisted treatment for SUD, including opioid use disorder, 30-day prescription drug supply offered at release, and linkages with community providers for behavioral health needs and peer support. To be eligible for the adult community reentry demonstration, beneficiaries need to be Medicaid eligible, have a diagnosis of substance use disorder or serious mental illness, and are post-adjudication. Next slide, please. The slide, so sorry.
No,
So these are some of the goals and objectives of this demonstration. So the population, as I said, is for Medicaid eligible inmates with behavioral health needs. The demonstration will begin 45 days prior to their anticipated release. And the tailored services include MCO enrollment, enhanced care coordination, initial pre-release visits with community-based providers. Care coordination meetings include pre-release reentry care coordination meetings include community-based providers, peer support, and the 30-day prescription drug upon release. So MCOs will be delivering this benefit. And the objectives are to increase coverage continuity, improve access to services, reduce morbidity and mortality, and lower the risk of relapse and recidivism.
Can I ask a question?
Sure.
Carolyn, how are people becoming Medicaid eligible while they're incarcerated?
So they, 90 days pre-release, the case managers from Department of Corrections will be sitting down with the resident, they call them residents, and either applying for a new Medicaid application or making sure that they have an active Medicaid application. And if it's new, they will apply through New Hampshire Easy and it will be suspended.
Wait, it'll be suspended?
They will be 90 days out because they're only eligible 45 days.
Okay.
So they'll be ready 45 days. So
Yeah.
the application will have time to be processed. And so within that 45-day mark, they will then be eligible for Medicaid.
Great, thank you.
Sure.
No.
I just wanted to mention that a lot of the work that we've done previously with this grant, when it was with the other agency, was setting up just outreach and coordinating with the DOC in order to help get people's Granite Advantage open immediately so that they could go into detox centers. So we had kind of like a direct line to Kevin Assad and New Hampshire Detox in order to get someone turned on within a couple of days so that they could leave and enter a detox program. So our organization has helped with that and can continue to be a
Have you
resource.
worked with DOC case managers or any of the internal staff?
Yeah.
Okay. Yeah, that's great because they can use all the help they can
Yes,
get.
especially because and it can be a little complicated because if the prison insurance is still active and we can't activate the Medicaid, things like that. And sometimes there are things that hold it up, but oftentimes, if it's knowing individual people when you work in New Hampshire, if we can vouch for Kevin Assad that the Medicaid will be turned on, it just needs that. Sometimes it needs a couple of days to work out the kinks. We can get somebody into a detox program.
I'm gonna ask my ignorant question because I hate to embarrass myself, but I'm gonna do it because there might be other people who have the same question. People are coming out of incarceration for an extended period of time, needing to go into detox?
Yes.
Mm-hmm. Yeah.
Wow.
Yeah.
Is it more county versus state or?
We're contacted with just a different, county, I'm sorry, or like departments of corrections will reach out to us individually. Sometimes New Hampshire Detox will say, we have an individual, can you assist them? They're so-and-so place. So it's from both, honestly.
I can tell you it was 10 years as a public defender. Contraband is very common. And for a long time, it was a struggle to be able to get clients into a detox after they came out of incarceration because the facility was unwilling or uncomfortable, put in that position of having to say, yes, this patient needs detox, even though they've been in our custody for 10 years. That's a tough thing to put them in a position of saying. So the ability to do this and the relationships that you have is
really exciting. But it's not.
Thank you.
Probably, the other part to highlight here is that the 1115 waiver is for people who have been sentenced. So I think that only in the county level, it's probably more than 75% of the people are not sentenced. And so that may be where more of this detox comes into play, because the length of stay typically is well under 30 days.
Thank you.
Yeah.
Dave, did someone put something in the chat? I can't see.
Well, just one way.
I don't know if someone
Might have been, must have been.
that's
Oh, in
on
the
the
chat,
chat,
yeah.
but I can't see what.
So this is the timeline of significant actions. As you can see, we started back in 2018 when the beginning of the 1115 began, and it just shows throughout the years things we've submitted, been approved for. We submitted the amendment in 2021, was approved in 22. We applied for the extension in September of 22. They gave us a temporary extension in 23 and our full extension in June of 2024. So the accomplishments for demonstration year 6 were, the demonstration was expanded to include coverage for SMI and SED. The demonstration was approved for an amendment in March of 23 to include the denture benefit. Demonstration covers beneficiaries who are Medicaid eligible to receive SUD, SMI, or SED services in an IMD. And beginning in January 1 of 25, community reentry demonstration, which will include, as we said, the package of 25-day pre-release services for inmates of a public institution within Department of Corrections at this time. We're only starting with the corrections, men's and women's and North Country. And for this portion of the demonstration, we are going to be piloting in counties. We're doing assessments on those right now, readiness assessments. So in spring 2024, the department entered into a contract with Unitas to provide closed loop referrals. The vendors engaged with providers to support their onboarding to the platform for general referral purposes. So we're continuing that initiative with closed loop referral. We will not be doing that for reentry at this time, but we're going to be phasing that in as soon as we can, hopefully in the next few months after implementation. So as you can see, we received a 5-year extension approval from CMS in June of 24, and we will have a draft summative evaluation due to CMS in March. Okay. Next steps. We are submitting the community reentry implementation plan so we can launch the authority following the approval by CMS. And we're going to continue to work with Unitas to design and implement specialized referral processes that are specific to several high priority populations. And there's just some other notes on there too. I got this update from Diana, who's working very closely, and she's very passionate about the closed loop referral system. So the providers will receive important care information about the individual to expedite meaningful and appropriate engagement care. And providers of services that are not traditionally participating in event notification systems or EHR electronic health records have appropriate access to a platform capable of supporting whole person care coordination needs. That's my presentation for our annual update. Does anyone have any questions?
I'd just like to make an additional comment. Part of the IMD utilization and getting compensation there where we wouldn't otherwise is what is also supporting the continued development and build out of our community-based services, such as the more extensive mobile crisis, CTI, and the like.
You were saying, Henry?
Yeah, no, I think the purpose of the additional funding on the part of CMS for the IMD components, SUD and SMI, is to provide additional funding for what our inpatient services, so that states have funding to be able to support their investments in community-based services. And just pointing out that that's another accomplishment of the waiver. That's a byproduct of that.
Nice. All right, thank you, Carolyn.
Thank you.
All right, so let's move into our usual and customary updates, and we'll start at the top with adult dental, Dr. Finney.
Morning. So I'm really happy. I've got two great points to make right off the top. We had an addition of 6 providers since my last report to you. So we're up to 174 providers in 127 locations. So that's significant movement in 1 month. And I think that a lot of that has to do with the really serious recruitment efforts that DentaQuest is putting into this program, and specifically Jen Dean, who is the person who goes out and is meeting pretty much on a daily basis with different providers face to face, so that they can have, a meaningful discussion about reasons to enroll versus why not to, and try to move the needle on that. So that's, a very good thing. We also had a record high claims in the month of October. We went over 3,000 claims for the month. And we also had the highest number of unique members served within a month. And I think that part of the reason we were able to do this is that at the mobile events, they have added extra dental hygiene slots. And so we are actually able to see many more patients each time there is an event. And so, we're watching this very carefully. But so at this point, through the end of October, we had 53,821 claims, and that covered 17,329 unique members since implementation. So it's very good that we're seeing a constant influx of new members into the program. And I think that we're sort of seeing the ball is rolling now, and hopefully, we'll continue to snowball in this manner. I have an update that I will share with you after the meeting, which has the next mobile clinics until the end of December. We have a robust schedule. They're busy every single weekend. We're having, good response. Solvair is doing a wonderful job, not only of reaching out to confirm appointments with members, but they also have wait lists for each location, so that if the day of there are last minute cancellations, they have individuals that they can call to try to utilize that time and space that's available. To date, they have had 121 events, 1,520 members have been scheduled, 1,190 treated, with 396 no-shows or cancellations. We are actively putting out information on social media for the department as those different mobile events come up. There is information on the Medicaid dental website. All the flyers for each of the events are there. Any of you can certainly feel free to please share those with any of your colleagues or the individuals that you work with to help us get the word out. And I think that's it, unless anyone has questions. Great.
Nice job.
Thank you. We have a good team. I have to give credit where credit is due. It's DHHS, Northeast Delta, and DentalQuest, and then also Solvair. And we are all still hard at work at the table. We meet a minimum of 3 times a week about various and sundry things related to the benefit. So rest assured that nobody is sitting back and resting. We know there's still work to do. So thank you very much.
Saturday and Sunday access to dental care is that's not available anywhere else. I think if anybody who's not on Medicaid's try to make a Saturday Sunday appointment.
Yeah, good luck.
All right, let's turn it over to Scott and hear how things are going in the DDU.
Yes, good morning. And my dentist doesn't even open on Fridays. So.
Same.
Yeah, so we did a little bit different this month. Some individuals wanted additional information. So as you'll see that we're looking at the children's cases. Currently, there are 36 cases pending compared to, excuse me, last month, 34 cases pending. There are now no cases over 90 days for the children, whereas there previously had been 3. Looking at the adults, we currently have 725 cases that are pending compared to last month with 779 cases pending. And 405 of those are currently over 90 days compared to 465 last month. Out of the 405 cases that are over 90 days, 365 of those are currently in the final stages. They're either in the process of being write up or the letters are going out, have gone out at that process. So the numbers are going down there. The contractor is fully onboarded. They're working. We have a second contractor that just came on and is taking some limited cases, as well as we did hire a full-time in-house staff person that is currently training. So another piece of information that someone wanted to know was out of the 725 cases pending, 255 of those claimants are currently receiving SSI or SSDI. I'd use that number cautiously. There is a margin of error in there from the reporting standpoint, whereas some of those claimants likely have a 0 entitlement monetary value on there, and those are being counted. We did discover that there's something that the field is doing as a workaround to try and generate some Bendexes. So it's likely a little bit lower than 255, but that's an estimate for you there. Another piece, Kristen, if you'll scroll down. Someone wanted to know the cases approved and denied. I ran a report from January 2024 through October 28th, 2024. And there was a total of 2,063 cases were received. 1,257 cases were decided. Out of the 1,257 cases, 770 resulted in approval and 487 resulted in a denial. So that's 61% of the cases resulted in an approval. And I believe that's all the information that individuals were looking for. Are there any questions on these numbers or anything else?
Scott, thank you very much. I know I always want a lot of numbers. It really, no, it's great. It gives me what I need. First of all, it gives me some relief. I hope that you're feeling relief finally with having a vendor who can support the process. We're clearly can see that we're moving in the right direction, and it helps me in the community to be able to communicate what you're seeing here. So thank you very much.
Excellent, thank you. Yes, they have come on, and they are very efficient now. Each week the numbers are actually going up and up, and the quality of the cases are outstanding. So thank you.
Great. Any questions or comments for Scott? Okay, moving right along. Henry, you've got, or actually no, Jordan has an item and then it's Henry.
I think I'm updating on the youth reentry program, and I know Carolyn may have something to add on adult reentry, though she gave most of her updates previously. So youth reentry, we're moving forward with implementation on 1/1 for state prisons and SYSC. We have built the fee-for-service benefit plan and a kick payment for the MCOs. that will be active on 1/1 for them to be able to deliver the services. In the case of TCM, it's going to be the MCO case managers directly delivering that service, or similar to, you know, how Carolyn has described through the 1115, the MCOs will be paying the community providers through that kick payment to deliver services that they're providing. We also got clarification from CMS that if a youth is eligible also for the adult program, so adult eligibility is 18 plus. Obviously, our youth categories go up to age 21 and then age 21 up to age 26 for former foster care. So based on those two criteria, right, youth can be eligible for both programs. So we have a benefit package and a kick payment organized for the both category as well. And we're working with our system teams to make sure that we're turning on and off the right benefits at the right time. Right now, our main kind of focus of work is in enrolling all of the providers that are going to be delivering the services. So obviously we have the rendering providers that directly provide services. And then in some cases, we have to look at group enrollments as well. For the most part, we're talking about, for youth, we kind of have the three categories of medical, pharmacy, dental. Medical services, we're looking at having Dartmouth providers provide those services for SYSC and state prisons, which will simplify billing. Obviously, Dartmouth group is already enrolled. We'll need to work on some of the rendering providers enrollment. For pharmacy, we're looking at the youth benefit program doesn't directly cover medications, but we intend to fill a 30-day supply of medications on release based on the date of release when full Medicaid is open. So we'll be looking at utilizing the local pharmacies to fill those prescriptions and just kind of working through details of how to coordinate that and make sure the local pharmacies know to bill Medicaid in the right circumstances. And then for dental, we're also working through separately for DOC, state prisons, and SYSC, who the rendering providers are. Are they enrolled? Do we need to get them enrolled? In certain cases, we may need to look at a group enrollment to facilitate that. But we're making good progress on all of that. That's the main focus right now. And then the other big update as far as reentry, we're applying for the CMS reentry planning grant, which is due next Tuesday, the 26th. It will help us to cover expenses related to providing training for carceral services on enrollment and submitting Medicaid applications. We'll provide some like one-on-one support TA as needed. We'll cover some technical support for facilitating telehealth, so telehealth booths, iPads, other equipment, and then supporting costs for state staff that will be supporting the two reentry programs, and then additional contractor time to support the implementation of reentry in state prisons, in SYSC, and then the 10 county jails that we are currently in the process of having sort of interviews with. We will be implementing over the next year and a half. I think we've talked about that a little bit. So as part of our application for the reentry grant, we're looking for letters of support from stakeholders across the state. And we are interested in MCAC being one of those stakeholders if, you know, that amenable. So we'll circulate a kind of a template to use for that letter of support if you're willing and able to provide it. I think we're imagining, you know, if Lisa Britt could sign on behalf of the committee. And of course, any changes or edits you want to make to that letter, but we'll give you just a template to get you started. Again, it's due next Tuesday, so we don't have a ton of time to facilitate that, but we'll get you a template ASAP.
And I was hoping that maybe the committee could give the authorization for maybe not only for Lisa Britt to sign it, but so that we can get it out next week, either Sol or a couple people to work on it on behalf of the committee. Basically, the grants are, New Hampshire's trying to be part of the first cohort, since we're also implementing early, among the earliest, and the grants are available to up to 56 different applicants, which is exactly the number of Medicaid programs and both the states and the territories. The issue is like, we're competing for between $1 and $5 million, is the available grant money. And so getting in early also might give us a chance to get more money to support this effort at the state level. I don't know, Lisa Britt, whether that's something, you'd be willing to speak to the committee about providing some authorization
Absolutely.
in that respect.
Yeah, absolutely. I think we would need a motion that would authorize me on behalf of the committee to sign on in support. Does somebody want to make that motion?
I'll make that motion.
Thank you. Do we have a second?
Second.
Kelly, thank you. All in favor?
Aye.
Oh.
Aye.
Aye.
Did you get all of those, Kristen?
Yeah.
Perfect. So Jordan, you and I can work offline and get this done.
Do you want to ask
Sounds
if
good, thank
anybody's opposed, just to
Oh,
make sure?
sure. I assumed nobody was. Are there any opposed? Okay, the ayes have it.
Thank you for doing that for the committee.
Yeah.
Appreciate that
Yeah.
work.
And thank you, Henry, for reminding us of Robert's rules.
No worries.
So for the adult piece, I just wanted to let everyone know that there is also a kick payment for the adult reentry portion of the demonstration. And we have been meeting weekly. We're having MCO weekly summits for readiness and what we expect from them, and any questions that they have, talking with their medical staff, and we've talking with their systems team, their medical staff, anyone that we need to get involved. We've really been partnering with them. So they're not going into this blind, and they seem pretty comfortable with what the ask is, and they're willing to work with. Their plan is to meet with the incarcerated individual soon after. We're hoping within days after the 45 days begin, so they can hit the ground running with them and get their services going and their appointments and whatever else they may need for coordination of their care. So that's really the only other major update, I think, for the adult side, but we are working closely with them and our systems team to have everything ready for 1/1.
Thanks. Great. All right. Are we ready to move on to Henry's updates?
Very good. So in terms of MCO contract, we are planning for an amendment to come to Governor and Council, hopefully for the second meeting in December. That will incorporate some of the changes that were made in the legislature. There's an appropriation for the prosthetic. So like I think a $900,000 appropriation to increase the codes levels to up 90% of Medicare as an effective date. There's also all this reentry kick payments. We need to incorporate those into the managed care contract. We also need to update the contract for changes in acuity related to the unwind. So those are the major things. I can't really get into a lot more at the moment, but as soon as the contract's published, we certainly can provide a link to that if you want to look at it. This basically covers the 6-month period from January through June. There's also some the CCBHC programs that we're looking to stand up will be part of that as well.
Certified Community Behavioral Health Center, just for those who are wondering what the acronym is.
Thank you.
Thank you for that. Oh, so you're going. Yeah.
Say it again slower.
Certified Community Behavioral Health Centers. It's a national initiative to certify centers, and it modifies their payment model, but it ensures access to all. Thank you.
Yeah. I'm sorry, I lost connection there, right? The only time this whole meeting I lost connection was when I was speaking. So that might be helpful maybe to do a little presentation on CCBHC's subsequent meeting, if you want that as an agenda item.
I think that's a great idea. Can you add that to the list, please, Kristen? Thank you.
I don't know if I missed anything else while I was temporarily
No.
disconnected. Okay. So the next item is the HCBS spending plan. I think we've had our quarterly updates to that approved by CMS. I guess probably the biggest piece of news is that CMS let us know last week that states could be eligible to extend their plans to put out any additional money that is in compliance with the requirements of HCBS. So I think the state's intending to do that. We don't have more than that to update you today, but we want to make sure all the money that we receive gets put out. Any questions on that one?
Nope.
In the waiver area, I think we've covered the key components here, except I think supportive housing state health plan amendment. I'm not sure I have an update today, other than I know the program area is working on trying to bring that live. If someone else has anything else to add to that, that's on the team.
No update.
So we could try to provide more of an update for next meeting on that one. Any other questions on department aspects?
Thank you, Henry.
You're welcome. Thank you.
And one other quick department update, because I forgot to mention it during our Medicaid and enrollment and eligibility updates, is we got our state plan amendment approval for kids with other insurance. So one of the requirements for the MSHIP population is that they don't have other insurance, but CMS, there's an optional benefit category that we can move those kids into for kids with other insurance, so we can maintain their Medicaid eligibility.
Which you'll do automatically. We won't have to take an action.
Correct. Yeah.
Thank you.
Great.
Yeah, this was a important issue for us to work through to preserve kids' coverage.
Thank you very much for that.
Thank you for pushing it.
My recollection is that we were going to take the HE 805 subcommittee off the agenda because it's kind of worked its way through the process, I thought.
Brian
No.
Clark. Brian Clark emailed the group. So we have a subcommittee meeting scheduled. Like Brian sent out information to us last week. Kara is reconvening the group. Yes. And we'll bring the feedback and information back. Does that make sense, Brian?
Yeah, that's my understanding as well. Expect an update in December.
Kara?
She's on vacation.
Okay.
Yeah, Kara's on vacation. This is Nicole from Crutch About, and she just wanted me to reiterate that she's on vacation, and when she gets back, she's scheduling a meeting.
Yeah, I'm working on that. I reached out to the group to schedule that.
So December update, folks.
Pressure's on. Okay. moving on to the consent agenda, we have a number of small amendments to the HEW 854. Can I have a motion to approve the items on the consent agenda? Thank you, Brooke. Do I have a second?
Second.
Who is that?
Joan.
Oh, Joan.
Thanks, Joan. All in favor?
Aye.
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 All opposed? Hearing none, the ayes have it. Thank you very much. Status on some of these others, I think, is there anything to expand beyond just the notation? No. Okay, excellent. Well, with that, unless we have any other business,
I just want to go back to the yellow highlight that's on your agenda. That's going to be one of my mantras for as long as I have a voice at the table. Just be aware that the public notices, right, are out on the department's website. So take the opportunity every month to go out and look and see what's out there, if there's something that you want to weigh in on. But that's your place to find public notices from the department going forward.
thanks, Kelly. Anything else? Okay, in that case, I'll entertain a motion to adjourn.
So moved.
Kelly, thank you.
Second.
Brooke seconds. All in favor?
Aye.
Aye. Any opposed?
Have a good Thanksgiving and thanks to everybody for all you do.
Thanks, Kelly.
Thank you,
you.
everyone. Thanks.
Great.